disorder. Another issue would be transfusion medicine, which means something wrong in the blood bank, and we have a PhD for that. Usually, some people go through medical doctor, then internist, medical doctor 7 years, internist 4 years, then we have subspecialty for hematology, oncology, nephrology, endocrinology, rheumatology, and also lung. These are several kind of subspecialty we have out of internist. But this is another one, PhD in blood bank and blood laboratory. They are master degree and they can go for PhD. Of course, they are working in the laboratory and they can't do consultation for the patient. When we have a 5 cc of blood with coagulation, anticoagulant factor such as heparin, then you do centrifuge. We have these 3 parts. The yellow part, 55%, is plasma. From that we derive 4 important drugs. One of them is albumin, the protein we have in blood plasma. First we have albumin, used for the patient who are in the renal failure, liver failure, cancer, or even for the patient who was burned. We use albumin to have protein. Without albumin, the drug cannot be delivered to the tissues. It's very important protein in the blood. Another one is IVIG, intravenous immunoglobulin. Several kinds of antibody we have, such as IgG, IgM, IgE, IgA. All of them would be IVIG. And it is derived from the human plasma. When you donate your blood, you will save 6 people. 4 of them would be from the plasma, 1 would be for the RBC, which is used for the treatment of the thalassemia patient, and 1 would be, which means, sorry, this is 4, not 6, 4, 5, 6 would be platelets, used for the patient who has thrombocytopenia. 2 other drugs would be factor 8 and also factor 9 for the hemophilia patient. So when you give your blood as a donation, 6 people would be saved. Also, you would be healthy, you would be saved as well. 6, 4 of them is for the albumin, IVIG, factor 8, factor 9, 5 RBC and platelets. Instead of going for hijama, which only save you, you will give your blood and you can save 6 people plus yourself. Usually we do blood test. When we do blood test, one of them important one would be CBC, complete blood count, or cell blood count. Means calculate or differentiate between RBC, white blood cell, hemoglobin, MCV, MCH, platelet. That would be very usual to see. Is there any anemia? Is there any infection? Is there anything wrong on the number of the cells in the body, which is very usual test we do every time. The second one would be hemoglobin electrophoresis, to check for 3 kinds of hemoglobin as usual. As usual, we as normal people, we have hemoglobin A and A2. We are normal. If there would be F or S or D or G, that's other kind of hemoglobin which can be checked by hemoglobinophoresis. It shows something which we'll discuss it today. Hemoglobin electrophoresis, once your life would be enough. You don't have to go all the time for hemoglobin electrophoresis to be sure, is it anemia, iron deficiency, or is it anemia due to alpha thalassemia or beta thalassemia or sickle cell anemia? This would be covered today. Another important test is coagulation test, because usually hemophilia would be for the male, and usually the boys should go for circumcision Without doing this test, there would be a danger to be diagnosed for the first time he is hemophilia and then would be dead because we didn't give them enough coagulation factor. So we do CT, coagulation time, BT, bleeding time, PT and PTT. These two tests would be used for the patient who are in the CCU and they are going to be covered by heparin or warfarin or with aspirin. We should check about PT and PTT. Otherwise, they are at danger to go for bleeding of CNS or maybe a stomach or retroperitoneal. That will be a very good test for follow-up of a patient with coagulation problem or not. Another important test is coagulation factor activity. In hemophilia A and B, we do not check on the amount of factor 8 and factor 9. This is not a good test. But the activity percentage is very important to see. Is it severe? Is it mild? Is it moderate? I will cover this in the hemophilia part, but it should be done for the hemophilia patient. Another test is ESR, erythrocyte segmentation rate, which shows inflammation, which shows infection. In the corona, in the different infection or inflammation, you will check ESR, erythrocyte segmentation rate. Also, of course, we have another test, CRP, for the pneumococc or something like that. Another important test is PBS, peripheral blood smear. You will see the smear of that kind of test we do as usual. To check, is there the number of cells fine? Is there anything wrong on the morphology of the cells? Are the RBC has got nucleated or they are normal, whatever. The last but not the least would be bone marrow aspiration. Bone marrow aspiration means take part of the bone marrow to see is there anything wrong on the bone marrow, or we can check it with the peripheral blood smear to see are they the same or is there any problem. Especially for the cancer, we go for bone marrow aspiration to do bone marrow transplantation. This is a test. After this test, we will go for a treatment design, which means bone marrow transplantation. Different kind of mutation can result on different kind of problems, such as beta thalassemia here, sickle cell anemia is there. Is there any loss of function? Is there any gain of function? So it results in different kind of disorder. I just wanted to show you how complicated this algorithm is there, so we cannot cover in 2 hours all of them. We just wanted to show you there is something wrong and it can result maybe in deletion of alpha globin gene, whole gene deletion, or maybe point mutation or upregulation or something like that. So it is a complicated algorithm we have. We as normal, when we are adult, we have hemoglobin A and A2, which means the genes alpha 2 beta 2 for the A, alpha 2 delta 2 for A2. Usually we have 97-98% hemoglobin A, 2-3% for hemoglobin A2. That is the normal ones. But if there is something wrong, for example, we have a huge amount of hemoglobin F, or maybe A2 is more than 2-3%, which means hemoglobin A would be decreased, then the diagnosis would be alpha thalassemia, beta thalassemia, or maybe we will see hemoglobin S, means sickle cell anemia. I will cover this today, but this is a normal one. Of course, how in the embryonic time, to fetal time, to adult time, it is changed. It is very important message we don't know clearly now. We say it as a circadian time or biological time of the body, how from the tissue to tissue it is changing. And if we know that, it would be a very good one for the regenerative medicine. This is a new branch of medicine, regenerative. Regenerative medicine, which means how protect somebody from being old, how to stop the process of aging. which means do not get diabetes, do not get cancer, do not get osteoporosis, do not get Alzheimer, do not get demons. Of course, it is a new subject, and when, for example, you use laser to be not something not on the skin, it is a small part of regenerative medicine, which is cosmetic or something like that. But a lot of effort has been done on the regenerative medicine to see how we change this circadian time from tissue to tissue.
Hemoglobin S what it was?
Sorry?
Hemoglobin S was
For the sickle cell anemia. I will cover this subject today. It is very interesting how it is controlled, how it is monitored. It's a kind of miracle of God regarding our tissue. First, we have yolk sac who do erythropoiesis. Then it changed to liver. Then it changed to spleen. Then it changed to bone marrow. Even in the bone marrow, first it is in the long bones, for example, femur. Then it changed to sternum, for example. But for example, if we want to do bone marrow aspiration of a baby, we will go to check the sternum in this figure. But we as adults, we will go for the iliac site, ilium bone, to do bone marrow aspiration. How it is changing, it is very important, we don't know yet. Another good message is the ring we have in the English language. We say use it or lose it. If you use your bone marrow, you will have it. If you don't use, it will be lost. For why? Because it will be fatty. Why it is changing from the bone marrow from the one side to another side is because of this. Exactly the same for the brain tissue, exactly the same for the muscle, exactly the same for the other tissue. Use it or lose it. So because of that, we can say the ischemic heart disease or myocardial infection or a stroke in the CNS is much less in the ladies compared with men. Because the ladies has got a kind of menstruational period, which means they will use their bone marrow much more than men. So men are at risk for much more myocardial infection or brain stroke. So when a baby come out, 75% he has got hemoglobin F, and it will be decreased to 0. If there is something wrong, it will increase, then there will be thalassemia major. Exactly the same as the one for the alpha 2 beta 2 would be for the adult. Otherwise, it will go for hemoglobin A2. So, because of that, we say alpha thalassemia can be congenital because we do have hydrocephalus, but for beta thalassemia, it's not congenital. At birth, he or she is fine. After few days, when the the blood cell of the mother will be decreased, then it will show itself. We can say the thalassemia major is inherited, it is genetic, but it's not congenital. But for alpha thalassemia, it can be congenital. Then, for example, we have hydrocephalus. At birth, there would be problem there. So let's go for thalassemia. Thalassemia came from the Greek word named as for the sea, which means it is close to the sea part of the world. For example, it is in Mediterranean region. We have it in the Persian Gulf region. We have it in the Caspian Sea as well. Why this region? Because the people who was carrier of this gene mutation has got an advantageous, a mutation or heterozygote advantageous, because when there was a malaria epidemic, they could be alive. Others when passed away. So we have a protection effect against malaria, of course, exactly for Vibrio cholera in the Middle East. In the Mediterranean region, in the Persian Gulf region. When we have an alpha or beta chain mutation, which means reduction, means we do not have enough hemoglobin production. It results in the hypochromia and microcytosis. The paint of the RBC is less. We say hypochromia, which shows by the MCH in the CBC test. MCH is for the hypochromia. MCV volume, this is the color. MCV is for the volume. It shows microcytosis. Microcytosis, not macro. Microcytosis. The MCV and MCH would be reduced both in thalassemia and in the iron deficiency, which means we should differentiate them by doing hemoglobin electrophoresis to be sure. Is it iron deficiency anemia or is it beta thalassemia major patient? So unbalanced accumulation of globin causes ineffective erythropoiesis, means we do have erythrocytes but they are not effective enough, and it can be facilitator for hemolytic anemia.
What was the MSC?
MCV is for the hypochromia. MCH is for hypochromia. MCV for microcytosis. This is two criteria we will see on the CBC test, in the beta test. Okay, alpha thalassemia is much more common than beta thalassemia, but it has a little bit better prognosis. So we hear about beta thalassemia, much less about alpha thalassemia, but it is much more common. Means we have a kind of a hemoglobinopathy. Means even we can have intrauterine disease. The alpha thalassemia will start during the fetal time of the baby, maybe result in death of the baby. I will show you the picture of that, which means hydrops fetalis. And interestingly, for alpha thalassemia, we do have a whole gene deletion. We, as normal, we have got 4 alpha globin. If there won't be any alpha globin, it can result in the death of the baby, which is named as hydrops fetalis. I will show you that. But the problem starts because we have homologous pairing with alpha 1, alpha 2, it can be resulted in the deletion. We have homologous recombination, we have, which is physiologic. I told you before, from the same father and mother, maybe we will have a tall boy, short boy, tall lady, short lady. Why? Because we do have a recombination. They are taking a kind of part of the genes from the father or from the mother. It is physiologic. But this physiology can be pathologic when it results in the deletion of the gene of alpha globin, as an example. Same sequence, when it read it and it show this one, it can be skipped from this one and go there. It means it will delete it. Or maybe reading several times, which result in duplication. Of course, it is not the case in this disorder, but we do have some disorder, deletion result in one disorder, duplication result in another disorder. But it is a good example of gene dosage. The copy number of the gene is very important. It resulted from homologous pairing and unequal crossing over, and it is interesting here. You see alpha gene are on chromosome 16. We are normal, thanks God we do have 4 copies of alpha globin, normal hemoglobin. If it results on the deletion of 1 alpha globin, it will be silent carrier, clinically benign. There is no big problem in this kind of patient when they lost one of the genes. If they lost 2 genes, it will be mild macrocytic anemia, clinically benign, alpha thalassemia trait. Means if 2%, 2 men and women marry each other, both of them has got alpha gene deletion, 2 genes, they are at risk to have a baby with alpha thalassemia disorder with the risk of 25%. If these 2 marry each other. With this one deletion, if they are married to each other, there won't be any problem in the baby. If they lost 3 copies, it will be severe hemolytic anemia, hemoglobin mild, clinically severe. We should do something for this kind of patient, for example, bone marrow transplantation. This is trait, The problem would be in the baby if both of them they are trait. Here, 3 copy, he or she has got a disorder, we should do the treatment. If 4 copy gone, it's against the life, it will be dead. Hydrops fetalis or hemoglobin Barts. One of the good example of gene dosage problem in the human being, both of these 3 copy or 0 copy, 3 copy deletion or 4 copy deletion, or having 1 copy or 0 copy, both result in neither release of oxygen. Usually what we need from the hemoglobin, it should give oxygen to the tissues. There is no alpha globin, there is no oxygen to the tissues, and it will be a sort of the problem for the patient. This is hydrops fetalis. What does it mean? Patient with severe alpha thalassemia and hemoglobin Barrett means 3 copy or 4 copy deleted, suffer severe intrauterine hypoxia. They are using the blood of bottle, but the hypoxia would be their result in the massive generalized fluid accumulation, result in death. Maybe in the it will come out death, or maybe in few hours it will be dead. Hydrops fetalis. And of course, it's not only by alpha thalassemia. There are other kind of mechanism behind alpha thalassemia. Sorry, in the hydrops fetalis. It is a clinically heterogeneous. Clinical heterogeneous, same as what I said for the headache. Several reasons behind one headache we do have. Okay, let's close the alpha thalassemia, go to beta thalassemia. Here is the chromosome 11. Alpha was on chromosome 16, beta is on the chromosome 11. We do have 2 beta genes, one from the father, one from the mother, 2 copy we have. Forget about 4 copy of alpha thalassemia, here is the usual 2 copy we have. Decrease in beta globin gene due to point mutation or something else cause a hypochromia, microcytic anemia, and the imbalance of globin synthesis lead to precipitation of the excess of alpha chain. We do have precipitation, means hemoglobin would be dead earlier. RBC, as usual, is 120 days life. For this kind of patient, it will go much more earlier. In the time of fetus time, beta globin is not needed because the mother hemoglobin is there enough for the erythropoiesis. But after life, it will start itself. So because of that, we say it's not congenital. It is inherited, it is genetic, but beta thalassemia is not congenital. Because at birth, he or she is fine. After a few months, it will start to show itself. This is exactly the same picture we will see in worldwide, whatever. From Iraq, from Pakistan, from India, from Kashmir, whatever you say, they have the same picture. What are these? They have a kind of yellow skin or brown skin. Why? Because there is precipitation of iron on the skin. Another thing, they have a kind of frontal bone bulging. Exactly the same for the upper jaw joint, it will be bald. Also, why? Because the bone marrow of this part of the body should go working much more. In us, it is silent. There is no need to go for that one because bone marrow of the lung bone or the iliac bone is working enough. Another issue will be hepatosplenomegaly. Liver and spleen will be bigger than normal. Why? Because of the precipitation of iron there. Because there is much more precipitation there. Even in the sickle cell anemia, we will go for removing of the spleen. I will cover this title in the future slide. But hepatosplenomegaly is an important issue when there is no treatment. If they will be treated very well, they will have a better life. Without treatment, they will are at risk for hepatosplenomegaly. In the beta thalassemia mutation, we have allele heterogeneity. What does it mean? We have one allele but 300 kind of mutation there, just as an example, an average, I'm not exact on the numbers. Means several kind of mutation result in the same disorder. Beta globin gene mutation. In different provinces of Iran, we know exactly which one is much more common. In, for example, Kurdistan, we will go to find that allele. In the Kerman, we will go to another kind of point mutation. Different province has got different mutation, so it will be allele heterogeneity. Patients with beta thalassemia major are at increased number of A2 and F. Instead of A2 we have in the normal life, so the A would be less, A2 and F would be much more. By using this test, we can say, is it alpha iron deficiency or it is the beta thalassemia major when we go for hemoglobin. But it doesn't mean all the time you should check hemoglobin electrophoresis. Once in a life would be enough. Is it beta thalassemia major or not? In beta thalassemia, sometimes it is minor, means they have a wild type copy plus mutant copy, or maybe wild type plus null allele. But when we have it in the beta thalassemia major, both allele are mutated, or one allele is mutated, another one is null mutation. This is beta thalassemia major. Means the father and mother should be minor, the baby at least 25% to be beta thalassemia major. Another picture of such patient. In alpha thalassemia, the severity is very different from each other, depends on how many copy number are mutated. In beta thalassemia, again, we have range of severity from mild microcytic anemia if there is trait. But for the patient, they have bone marrow hyperplasia, hemolytic anemia, growth retardation, jaundice, hepatosplenomegaly, bone marrow expansion, and result in the multiple bone deformity. Usually when we wanted to do supportive therapy, we will give them blood transfusion, red blood cell or packed cell. Also, we should remove iron overload. If a doctor by mistake, because the clinic is the same, give iron to this patient, it would be worse and worse situation for the patient. We should remove the iron, but maybe by mistake, as MCH is low, it says, oh, it is an iron deficient patient, let's give iron. For them, it's not a good one. We should remove the iron by using desferal or deferoxamine. Desferal is a pump used as IV. Deferoxamine is tablet. And usually, somehow, maybe sometimes we have in the reduction because of the sanction we have in Iran, and you will see on the news the thalassemia patient are concerning, they are saying what is this, why this is happening, and something like that.
Can you write it on the board?
Desferal and deferoxamine, they are iron overload removal. Desferal is it IVIG, the intravenous use, deferoxamine, it is a tablet. 2 iron overload removal. 2 drugs. So this is very usual, we do all the time. Hopefully by this supportive therapy, they are not growth retarded, they are not mental retarded, they don't go for infertility. Without treatment, they are at risk for growth retardation, infertility, or maybe mental retardation. Now in Iran, we have a medical doctor who has got a thalassemia major, but hopefully good treated, and he is a doctor now. Otherwise, because of the reception of the, precipitation of iron in different tissue can result in the different complication. prominent cheekbone and protrusion of upper jaw resulted from expansion of marrow cavity in bones and skull and face due to ineffective erythropoiesis. They have to work much more. Thalassemia can be seen in the Middle East, in African, in the Mediterranean region, Indian, Chinese, and Southeast Asian descent. But maybe not in the Caucasian, not in the Jewish Ashkenazian. They don't have it. But they saw this disorder when Iranian or Pakistani or Indian immigrate to the UK or different European country. They saw what is this beta thalassemia major there. You see, for the UK, for alpha thalassemia is around 0.1%. But for the habitants in the Southwest Pacific Island, 49%. You see how different ethnicity, how the number is changing. About 50 times more in this one comparing with the other one. Same for the beta thalassemia as well. So we usually go for a screening test. In Iran, we have a kind of role by the government. When they wanted to register their marriage, they should check for the CBC, both men and women. Whatever, if they are old, sugar mom, sugar daddy, or something like that, or for the youngs, they should check for the CBC. If the MCV and MCH was low, then we should check, is it iron deficiency or is it thalassemia? Then we will discuss them. You are trait for beta thalassemia. You are at risk of having a baby with beta thalassemia major, 25% in each pregnancy. Think about it. Is it better to forget this marriage or you wanted to go carry on? If you want to go carry on, you should check for the mutation, and all the time when the mother is pregnant at age of 4 months, we do CVS sampling or amniocentesis to check the baby. Is it healthy or is it carry on? Is it patient? You can go for the therapeutic abortion for such kind of patient, for the alpha thalassemia major, for beta thalassemia major. But trait, we will not go for therapeutic abortion. So that's what we do for prevention. Maybe in other countries, I don't know, but if you let me know by email or by sending my message, it will be a good one. I don't know about Iraq, I don't know about other countries as well. But in Cyprus, they do checking the ladies when they are in the high school, or for the men when they go for the military action. But everybody around the world says Iranian system is better than the others because it will cover better than other intervention we do have in different health sectors. For screening would be MCV, MCH, confirmation would be by the hemoglobin electrophoresis, and then we do detection of mutation by molecular study. Then we will go for treatment. Sometimes it is supportive, means giving blood to them and removing the iron. But if we wanted to go for the curative, we have to go for bone marrow transplantation. Of course, sometimes because of the big spleen they have, we have to go for a splenectomy. Appendicectomy. Ectomy means removal by the surgery. Otherwise, there is a big danger for them to go for the spleen infarction or maybe death. But the cure would be bone marrow transplantation for this kind of patient. Hypochromic microcytic anemia is due to iron deficiency or chronic disease or alpha thalassemia, beta thalassemia. To check for that, in iron deficiency there would be decrease in the ferritin. But for chronic disease such as kidney problem or liver problem, ferritin is normal or even higher. Saturation iron is less in iron deficiency, is less in the chronic disease. TIBC would be increased in iron deficiency, but it decreased in the chronic disease. saturation of the iron is decreasing the iron deficiency, but it is normal or elevated in the Crohn's disease. This is usual way to differentiate between two clinics, which is the same. Clinic is the same. We have to use laboratory tests to differentiate between these two groups. Hypochromia means less color of the hemoglobin. Macrocytosis is too many small non-nucleated RBC. And in the US, okay, you can go for a break 10 minutes, then we go for sickle cell anemia.